Certainly remember back in the days when he was already starting some pretty impactful research back in Columbia and New York Presbyterian, and going through the academic ladder in Chicago, and he's now chair of neurology at Chicago, actually for the last almost 7 years now, 2019. And so delighted that he chaired the AHA guidelines. He's here, and we'll turn it over to him.
Thank you. Again, a kind welcome from Sean, and I also marveled at your awesome career, and many in this group know the impactful work you've done over the years. So I had, the pleasure of chairing this writing group. It was a great honor, and I had wonderful colleagues. I wanted to just point that out right from the start here. That is really a team effort. It takes a huge team to put something like this together. It had been 7+ years since the last guidelines were written. And so we had experts from all disciplines, really diverse group that informed these guidelines. And it included nurses and physicians and also a patient representative. We also had a really robust peer review. This was new in the AHA, and they really wanted us to engage with and have a process that felt collaborative with the peer review committee. And this was headed by Dr. Lara and Dr. Broderick, who really did a fantastic job giving us feedback and many comments, over 500 comments over the course of peer review, which was really helpful. And then finally, we did our best to solicit our relevant societies to endorse these guidelines, which we were grateful when they did. So I'm going to jump right in and talk a little bit about these guidelines and what we tried to focus on. We had to scope the guidelines a bit, which every guideline has to do that. What do we start with? Where do we end? Are you able to see and see the screen?
Yes, we can see it.
Can you please ask everybody to mute their speaker, because we are listening to somebody's phone.
Yeah, that's what I heard. I was just wondering if somebody had trouble seeing. Okay, I'll continue. So we limited our scope to some pre-hospital, of course, which is very relevant to acute ischemic stroke management, really up to early hospital management. We did not really get too far into secondary prevention or hospital diagnostics, which really is part of the secondary prevention guidelines. So just a slight difference from the 2018. And we also limited our literature review to approximately the end of March of 2025, which is problematic in this field, as you know, because the deluge of trials, especially impactful trials that are being published, is quite large. And so we recognize that every guideline has a little bit of a postmark date or a date to it, but those are some of the characteristics. Just some framing of a class of recommendation and level or quality of evidence. You're probably familiar with this, but really the strongest class recommendation is when the benefit is much greater than the risk. And we use terms such as recommended. It's sort of like a should be done type of recommendation. That's the green. The next one is where there's probably enough benefit over risk and something is reasonable. A 2A is a really strong recommendation. So keep that in mind throughout, that a 1 and a 2A are really strong recommendations. A 2B is probably a fairly weak recommendation. There's a lot of uncertainty around it. And then class 3s are divided into those that are no benefit and those that are harm, where the risk is greater than benefit. And the level of evidence is, based on the quality of the literature supporting those recommendations, and they could range from more than one randomized clinical trial, so that would be a level A, a single. Moderate quality would be a B, randomized, and then non-randomized, and then low or limited data. So let me just get into it and just walk through, and probably I'll try to do it in about 20 minutes. Some of the updates here. In the pre-hospital assessment, not a lot of things are changed here. I think we we recognized one of the opportunities we had was to delve into pediatric stroke pathways and care. And while the evidence here is less than adult by a lot, we felt it was important to take this step. It was a really awesome idea that several writing group members had, and it was largely endorsed by, of course, HA leadership, and the peer review committee also received it favorably. So the one call out on this slide is the insertion of the recommendation, again, a weak recommendation where, again, there could be a lot more research in the coming years around pediatric assessment and transport. And so screening those patients, developing new pediatric stroke screening tools, we think is necessary. And there's some good screening tools out there, but hopefully more study will be done in that space. The next pre-hospital recommendation that we debated considerably was around this concept of bypass and destination management. Here, I'll call out two things. One, that we really intentionally inserted the concept of door in and door out. There's a typo in this, but it's door in and door out with a dash, not door indoor. But just so that transferred patients, the systems are really working to improve that efficiency of moving a patient from one hospital to another. And then the destination management, we took a very nuanced approach, especially with regards to access to thrombectomy centers, yes, no, and then the efficiency or how well coordinated that system is. So it's a little bit nuanced, and here's a way that Dr. Zackerson displayed it at ISC, which I thought was very useful. So you have a suspected LVO, you have in one category no local access, and in that situation, when you don't have good access to a thrombectomy capable center, we gave a reasonable level of recommendation here that those patients could be transported to a TSC, because they would increase hopefully the use of EVT and reduce the times to EVT. In the scenario where you have access to a thrombectomy capable center, we did make this distinction that in those that that access includes potentially a proficient stroke system of care where thrombolysis, delivery, and transfer times are really exceptional, such as in Catalonia, Spain, where RaceCat was conducted. There was no benefit of bypassing that local non-thrombectomy capable center. While in systems where there's probably less proficiency, or that there's less developed stroke care, that decision around transfer to a thrombectomy center may be something to consider. Let me move on to the mobile stroke units, which some of you are very expert in. We thought the evidence now clearly supports their use and recommended it at a core level of 1. And here, the only caveat is we understand the limitations of mobile stroke units because of cost and practical feasibility. So we only wanted to emphasize that we inserted the phrase where available. And it's not to say we don't want to encourage it. We just recognize that not everybody could just turn one on. There are other practical considerations, but this is a high level, a high class of recommendation because of the data to support its benefit. Moving on to now the emergency room. I did want to point out a few things here that will lead to conversation around extended window thrombolysis. We again emphasize early rapid imaging. We did not state it had to be CT imaging, although we recognize that CT is much more likely to be conducted within the 25 or so minute timeline, which is, I think, an expectation. If you were to be using MRI, you'd have to have that same quick, rapid access to MRI to assess for tissue tissue viability, just in the initial assessment. And then in the extended windows, we noted that prior guidelines had recommended DWI flare-based thrombolysis, and we wanted to be more inclusive and had included an approach to use CT or MR perfusion-based selection as well, and that'll come up a little bit later. In thrombolysis, the one thing that I think we spent a little time on the writing group discussing was how do we kind of ensure that people are thinking about thrombolysis less as a checkbox and more as an actual individual decision, especially with regards to disabling deficit assessment. And so we're trying to ensure that patients who don't have disabling deficits based on PRISMs and other studies are not treated with thrombolytics, but that those with mild disabling deficits are treated, and to open a little bit more room for the individualized decision-making for those patients that have comorbid conditions, contraindications potentially, relative contraindications, but really try to help the practitioner think about them in categories of risk and benefit. And I'll go over that in a minute. So this is the table that was in the guidelines around how do you assess disabling deficits. This is from the PRISMs trial, so I think some of you may be familiar with it, but it's very useful, I think. Again, it requires a little bit of individualized thoughtfulness, but I think it's important to consider thrombolysis using this framework. This was that consolidated table that we inserted in the guidelines that attempted to say, okay, there's consensus around some of these things, especially the green and the red, that the benefits may be really much greater than the risk in certain comorbidities that are listed on the left-hand side of the screen, and that could include things like an extraaxial neoplasm. And on the right-hand side, the red, there are certain things we would never want to treat at this point based on either studies or consensus. And in the middle, there's certainly a number of things that we want to kind of encourage some individualized decision-making, both with the patients and families, but also the relevant consultants who may be able to inform whether you should or should not thrombolyze. The next major update in thrombolysis was, of course, around TNK. Many of you are already using TNK and have switched from alteplase to tenecteplase. There was a lot of studies in the years intervening between the guidelines that had shown non-inferiority of tenecteplase to alteplase and really comparable efficacy and safety at the 0.25 mg per kg dose, while the 0.4 mg per kg dose was potentially harmful. And so the recommendations are that 0.25 should be considered as an alternative for tenecteplase to alteplase, and that 0.4 mg per kg of tenecteplase is not recommended because of no benefit in our analysis, but also a concern for harm. TNK, for those that are not used to it, we recommended going with the FDA's approach, which was a banded weight-based approach as opposed to a 1 kilogram band. It's a 10 kilogram band, and that's, again, something that's new to people. And so I think using this table may be of value as you implement tenecteplase in your health system. Extended window thrombolysis, we talked a lot about this. There had been, of course, trials done, and there's actually continuing to be trials that we obviously didn't include because they're after our date of literature review. But we felt that DWI flare mismatch had been in the previous guidelines for extended window thrombolysis. Extend was published after those guidelines, and there have been other studies since then. And the writing group felt that we should try to incorporate them into these guidelines. And the thing that I wanted to point out is we largely took criteria from Extend, and we can talk about that. I'm sure there's questions around that in creating the recommendation number 2, which is that patients who are presenting in that 4.5 to 9 hour window from last known well or within 9 hours of the midpoint of sleep. That's, again, from Extend, largely thrombolysis may be reasonable. It should have actually, we're fixing the typo. Somebody called it out at one of our fire chats. It should be is reasonable. And that then aligns with a DWI flare approach we think is important for practicality. Many centers don't use DWI flare because of the limited access to MRI, and CT perfusion, for example, could be more generalizable. The data around the 4.5-hour to 24-hour window in the presence of LVO is largely come out of a few trials now, even post these guidelines, but TRACE-3 in China, and now HOPE from China as well last summer. And the reason why we did not give this such a high recommendation was in part because we thought we needed a little bit more generalizability outside of China, plus that Timeless had been conducted internationally and found no benefit of TNK, in that case, thrombolysis in the 4.5 to 24-hour window in the setting of LVO and getting EVT. So we thought that this would be something that's reasonable if your patient is unlikely to go for EVT, even though they have an LVO. This is quickly, just we know that, of course, most was published during this time period, and of course, we have no evidence of these adjunctive antithrombotics having benefit in the setting of intravenous thrombolysis, so they're not recommended. Going on to EVT, and I'll again try to go through this quickly so that we can have a lot of time for conversation. The imaging recommendations for EVT are important to reflect on. There is a class 1 recommendation for vascular imaging in those with suspected LVO within 24 hours. We retained a recommendation, a strong recommendation, a 2A class recommendation for adjunctive or advanced imaging that includes CTP, MR, a DWI flare, or DWI PWI mismatch analysis in the evaluation of EVT, if it could be done quickly and is available. So we're not discouraging it. We're just saying that it need not be done in everybody to make a decision around EVT selection, and I'll go into why. There is a really great figure about the use of aspects, which is figures large in our algorithm, in our guidelines, in terms of evaluating patients for EVT. And so this is useful for those that have not thought about aspect scoring, but I think it's becoming more and more commonplace. This figure was created by Dr. Gonzalez, Nestor Gonzalez, who was a vice chair in the committee, and I thought it was really useful. It looks at both pediatric and adults. It looks at time windows, a categorization of tissue injury in adults, largely based on aspects, and in select scenarios in children using perfusion imaging, and gives you a sense of the level of evidence and class of recommendation for proceeding to EVT. And here's that summary. So essentially, in the 0 to 24 hours between an aspects of 3 to 10, we're recommending EVT in those patients with anterior circulation, large vessel occlusion. And there are some fine points here around the 3 to 5 aspects in the 6 to 24-hour window that notes that an age cutoff is important to keep in mind in that subgroup, because this is largely dependent on one trial, which was last day. And this is another way to summarize it. Dr. Gonzalez shared this at ISC. So essentially, it's a core 1 for EVT in the 24-hour window with aspects of 3 to 10. But in the 3 to 5 group, in the 6 to 24-hour window, you have to keep in mind how this last day trial was done. Age was an important criteria for exclusion, and amongst other listed items here. Now getting on to where things were a little less strong. These are the 2A recommendations for EVT. In those that are presenting within 6 hours but have a modified Rankin score of 2, we thought it's still reasonable to offer EBT. And then in the 0 to 2 group, under 6 hours, again, drawing largely from last day, where in their analysis of subgroups from 0 to 5 aspects, the 0 to 2 aspects group did seem to also have the similar benefit. And so again, drawing from a small subgroup of one trial, we gave this a 2A recommendation. And these are, again, the patient characteristics excluded in last day. How about MeVos? Well, MeVos were an important controversial topic right around the time we were finalizing our guidelines a year ago, right after ISC. And those trials were published in early 2025. And so based on those trials, we felt that the non-dominant proximal M2s, the ACAs, the PCAs, we did not see that there was evidence of benefit based on those published trials, so EBT was not recommended in that group. We did call out that the dominant proximal M2s were not included in those trials, and we thought it was still there reasonable to offer EBT, although again more trials were needed in that subgroup directly testing that hypothesis. We did leave open, which is fortuitous and maybe a little bit of thinking about where the field was going, that there would be more studies of this and more devices that were technologically developed for the distal, medium and distal vessels. And certainly that's what's going to happen, is that these newer approaches will hopefully find efficacy in this population. Posterior circulation, of course, there was a bevy of new trials, and here we had two recommendations. One was the primary group in the posterior circulation trials with an NIH stroke scale greater than 10 and a PC aspects of greater than or equal to 6, where EBT was shown to be better than medical management. But the group that we also called out where there might be some benefit is this group of NIH stroke scale scores 6 to 9. Again, more data, more study is needed in that group, but we did want to include that as a 2B recommendation. Pediatrics, lots of, again, excitement around what we've tried to do here. We've created some imaging recommendations for pediatrics with a preference for MR-based imaging because of the risk to children to have radiation and contrast. And so there's a primary recommendation for, of course, brain imaging, tissue imaging that's similar to adults, but then vascular imaging with MRI, MRA is the preferred approach in children. And many of the larger pediatric centers know how to do this. They know how to do it quickly. And I think we need to start to standardize that and share those best practices. And if MRI or MRI is not available, then CT, CTA is, again, a reasonable approach. Thrombolysis here, we took a leap based on really small data that there's safety of thrombolytic use in children. This is not, again, a high recommendation. The 2B efficacy is uncertain. There's a lot of challenges in doing a study within 4.5 hours in children. Their delayed presentation, the sort of high rate of mimics in this population. And so I think this will be challenging, but we felt like we should put something out there and let the field sort of push forward to try to improve the evidence base. In pediatrics, we also reviewed published literature, again, not a lot of randomized trials here to look at endovascular approaches. And here we came out with a couple of 2A recommendations, which I think is important, that in children greater than 6 years of age who are presenting within 6 hours, that EBT can be effective, and that within 6 to 24 hours and potentially salvageable brain tissue on, again, on a perfusion advanced imaging approach, EBT, again, can be effective. So these are, I think, important guidelines as we think about our LVO patients in children greater than 6 years of age. And the reason for that is that I think those centers need to begin to set up protocols to identify them quickly and then hopefully get them to a center where there are experienced neurointerventionalists. In the youngest group, 28 days to 6 years, there was a lot of uncertainty, and we left this a little bit with a weaker recommendation, a 2B recommendation, so it may be reasonable. Two important derivatives that came out of the guidelines that I think it's worth this group reading and sharing with your colleagues. One was this figure that was in the AHA derivatives products that was not in the guidelines, but it's really useful. What we're trying to do here is encourage pediatric stroke readiness. And that's thinking about, who your team members are. How do you think about your ability to care for pediatric stroke patients? Do you have the right imaging access? Do you have the right people to try to get somebody an MRI, which might require anesthesia, for instance? Do you have access to interventionalists? And then can we develop a pathway at some of our pediatric hospitals? So this is really a call to action more than anything else. And I think our pediatric colleagues deserve that. And also, I think have been very, very, very excited about the next steps that they want to take. This was an attempt to create a pediatric stroke alert pathway. Again, I think this will be fleshed out more as pediatric centers begin to implement this, but our colleagues in pediatrics helped us develop this derivative product, and it may be, again, something you start to try out at your individual centers. Quickly, ending with a few other smaller updates. Blood pressure control in the IVT and the EVT population has been also studied in the last several years. Several of these trials are listed here. We, of course, learned that aggressive or intensive blood pressure lowering to a less than 140 millimeters mercury systolic in both the IVT population, where it was not associated with benefit, and in the EVT population, where it was potentially associated with harm, are therefore not recommended. We also talked a little bit about early medical management that included antithrombotics in the guidelines. So post-EVT and post-IVT decision making. If somebody's coming in with acute stroke, mild stroke, or high-risk TIA, we know from the secondary prevention guidelines that DAPT is beneficial, but we expanded upon that slightly because of the INSPIRES trial, which was published, and found that you could potentially go out to 72 hours in a subset of patients. So we wanted to include this in the algorithm to treat minor stroke and high-risk TIA. Early anticoagulation has had a lot of fanfare in the last several years, with several trials conducted, again, suggesting that there's safety to early anticoagulation, oral anticoagulation with DOACs, rather than waiting. And so we came away with a 2A recommendation that it's a reasonable approach. It's low risk, though the efficacy, again, of that approach in terms of superiority to delayed treatment is not yet established. Blood glucose, we learned from SHINE that, again, intensive blood pressure control to 80 to 130 milligrams a deciliter is not beneficial. And so that is a new recommendation, not to try to get somebody into a very tight range. Rather, a range in the 140 to 180 range is probably good enough. A couple of other updates, and I'll try to, again, end with plenty of time. The first one is we've had a lot of interest in trying to deal with the secondary complications of acute ischemic stroke, including malignant cerebral edema. Unfortunately, currently, we still don't have a medical treatment that's going to make a difference, and this was from the CHARM trial. So right now, that's a no benefit for the drug libacetamiide that was used in CHARM. And I know further studies of this drug in select subgroups are being considered. So this is not dead, but for now, there's not really, besides a bridge to surgical management with osmotic therapy, there's really not a strong benefit of medical treatments. Dysphagia, I wanted to call out one thing, which is the insertion of a 2A recommendation for pharyngeal electrical stimulation based on small studies, but a view from many of our nursing colleagues that this was safe and may be something that sites could start to adopt because there's at least a signal towards benefit and low likelihood of harm. And so a two-way recommendation here is to hopefully encourage more people to think about this technology as a way to improve swallowing outcomes and then improve overall outcomes. Going back to medical management, I already said this. Let me go to the surgical management, which is here. A slight change that we have a level 1A recommendation for the under 60-year-old within 48 hours with a malignant MCA infarction. Again, good, strong evidence base for that. In the older population, greater than 60, we have a 2B recommendation, may be considered to reduce mortality. These are about around cerebellar infarction. High, again, degree of benefit for some of these interventions, including ventriculostomy, decompressive craniectomy. It, again, is based a lot on characteristics of the infarction, and we stipulated what we think that should be, a volume greater than or equal to 35 mLs that would benefit from decompressive suboccipital craniectomy, and that it should be accompanied by dural expansion. So that takes me to the end, and I promise to give you plenty of time to ask me questions. I wanted to acknowledge we had this great team of guideline ambassadors who worked on the slides. Some of the slides that were prepared I used in this presentation, and so I want to call out those that really did a fantastic job taking the guidelines and trying to make them digestible. And you can find them online. You could use them. I hope you do. And I hope I covered some of the salient updates from the 2026 guidelines. Okay, I think I stopped sharing.
That's wonderful. Thank you so much. I summarized a couple comments, questions already from the group. Maybe I'll just throw them out there and then people can start asking. The first one was about if the patient's on a DOAC within 48 hours. There's been a lot of conversation about this, that being on a DOAC within 48 hours is a long time. So somebody who took 1 hour or 12 hours or 48 hours, any comments, or did the committee have any thoughts on this?
We're silent on it to the degree that we included in that sort of yellow box, the category where there's a lot of individualized decision making. There's some really, good observational data that there's safety in treating patients who are coming in within 24 or 48 hours of DOAC use. However, they're not the best methodological studies to test that, and I know that there's actual trials being prepared both in Europe and in the U.S. to study that. So we're sort of silent on this, and I think it's where the individualized decision making makes a lot of sense. So you could take a time-based approach, which is what I think the question alludes to, is 24 or 48 hours the same as within 1 hour or 2 hours. That's a conversation that you could have qualitatively. And then you could quantify it potentially by sending, a direct assay of the concentration of the DOAC in the bloodstream. And if you have that availability, I suppose you could use that again in that individualized decision making. We're not going to probably have data to tell you that it's beneficial or not yet.
Anybody else have any comments on the patients who are on DOACs? Any further questions on that from anybody in the group?
I don't have a question about DOAC, but I do have a simple question. I don't want you to be silent here. The CTA software, is there any software you can recommend? Because my CT software sucks. So is there any specific software you can recommend?
Well, you mean the vendor of the CTs themselves, or the software for processing?
What is your good experience with your software? We will follow you.
Now I can't really. I can say I've actually in our health system, just for full disclosure, we've adopted the Rapid tool, which was something that we decided as a group another health system that I work closely with is using Viz, and they're happy with the tool. So I would say that it's the choice of the team members and really comfort level of what the interface with that system provides and the satisfaction they have from it. So I think they're getting really good at this. I certainly have a lot of confidence when a software identifies an LVO on it. I think there's still some nuance to Mevos that interventionalists sometimes have to actually look more carefully at, rather than relying solely on the output of the software.
Let me clarify my question. I think I'm very happy with Vizi, but I'm talking about the CT using the specific software, the Siemens using some different software, and Philips use different software.
Yeah.
My experience is not so great. I cannot see the ischemic core with Penumbra, which I should see it. But I have no problem with Rapid. I have no problem with Vizi, but I'm talking about specific software.
Actual vendors and the machines themselves. It's probably a little bit over my level of expertise, to be honest with you. I don't know if someone else in the audience is more of a radiology background, can speak to the technical differences between the different vendors for these CT machines. I actually don't know.
I don't. I think let's move on to our next question. There was some conversation about thoughts on thrombectomy that is in the kind of aspects really low, 0 to 1 or 0 to 2. Any thoughts on that? There was some interesting thoughts about this, that it was even being considered.
Well, I think last day is our only real place to look, and it's a small group. It's a couple of hundred people in that category of 0 to 2. And when they did break it out by 0 to 2 versus 3 to 5, the signal and the effect size was the same. So we're basing it on that. We recognize it's one trial. We recognize it's a small population within that trial, and we recognize that there were certainly exclusion criteria in that trial. And most of the patients, I think the median time from onset to enrollment in last day was 6.5 hours. So that's why we limited that recommendation to the 0 to 6 hour group with a 2A. So all of those caveats should be considered when you think about those aspects 0 to 2.
The question that came up was so EBT for PCA occlusions. Any comments on that?
Well, it's evolving very fast, and at the time we wrote and finalized these guidelines for endorsement and all of the steps prior to publication, we had distal that was published, and distal of course included PCA strokes, and again did not find benefit of endovascular thrombectomy in that whole population, but that included PCA occlusions. So we felt that at the time that is the right level of evidence to use, and did not support thrombectomy. There have been some new trials, and including just last month or this month, and so I think this is where the guidelines need to be a little bit more real time. Edits and potentially updates done much more frequently than what happened between these two guidelines. And so I expect that there will be updates more regularly, potentially even within a year, because these trials are going to hopefully change what we wrote.
Yeah, I
am. I think there's a question from Jenny Sitter in Oklahoma.
All righty.
Yeah, so thank you very much for a nice presentation. My question is about this pathogenesis and stimulation of the pharynx. As far as I know, the trial which was testing this, I forgot the name of that, but it was not published yet. But what the recommendations are based on?
Say that again. I missed the first part. I'm sorry.
Yeah, so it's about pharyngeal stimulation.
Oh,
So-
right.
Right. So as far as I know, that trial was not published yet, or maybe I missed it. I don't know. What recommendations were based on?
Yeah, they were based on several trials, several done over the course of the last decade, actually. We go back into the mid 2000 teens. Our review group, really was interested in looking at this. There are some limitations to the studies. They didn't really have, besides dysphagia improvement, other functional outcomes. So there are some reasons why you have to be cautious with this. The trials were, somewhat underpowered and small in size. So I would, say that we debated a 2B and a 2A. We came down on 2A largely because we felt like the harm associated with it was low. We just didn't think that this is a harmful thing and that there was enough likely potential benefit that we felt like it's something if you have availability or have the device in your health system, it's probably useful. As with MSUs, there's cost implications for these things. And so we're not going to be able to tell you you must go out and do this. That's why a 2A is it's a reasonable thing to do. We can't say it's a must and you have to do it.
Thank you.
Here's a question from Tai Sheng from UT Southwestern about the issue of these Plavix metabolizers and doing the genetic testing. How quickly can this get done when you're trying to make a decision on dual antiplatelet therapy within 72 hours?
It's a great question. We didn't obviously spend any time on the guidelines on this. It was a little bit beyond the scope, but we did touch on DAPT, and your point is well taken that, as we think about DAPT in a more personalized way, specifically related to clopidogrel versus ticagrelor, I think you're right that as we get more sophisticated, we should think about these approaches that hopefully will guide you towards the drug that is best suited for that patient. It's not in the guidelines because this was not something we focused on.
Then Indrani Acosta, who's in Orlando, Florida, she raises the kind of the question I guess we all kind of face, which is that, to the extent to which the guidelines, help us if we had an adverse event that happens, and we said, well, the guidelines said that we could, it was reasonable to consider to give this thrombolytic agent in somebody with a DOAC within 48 hours, and then they have a fatal bleed. Maybe, I don't know whether you could comment for the group overall about, using the guidelines to help you in your treatment decisions from a legal perspective.
I'm not a lawyer, so I can't really speak knowledgeably about how that plays out in a court of law. But I think guidelines are just guidelines. You're the doctor, you're treating patients, you're making decisions with hopefully a shared decision-making model. You have other team members also on your team, and you're documenting those decisions, hopefully in a fair way that reflects how you came to that decision. And usually, I think if you are doing that with that individualized approach with the patient or family member, where you've explained the uncertainty in this situation, because that's what this is, it's an uncertain one, and the decision collectively was to move forward, I think that's a pretty safe legal argument.
Okay, and now we have a new question from Rahul in Tulsa, Oklahoma. Talking about, if you're going to use advanced imaging for these extended time windows, that, it leads to obviously some delays, depending upon your MRI availability. So I think he was saying you don't see enough strong evidence to rely on CT perfusion for extended window thrombolysis. MRI mismatch appears to be more reliable, however, very difficult to get.
So good questions. First part, which is, door to needle. I think a lot of places exclude door to needle, the extended window from their door to needle metric. So the door to needle really is in the 4.5 hour window that I think people are accountable for. if somebody's presenting in the delayed window, I don't know how sensible it is to look at door to needle, but it's a fair point. I think that's not the same. It's not apples to apples. As far as the CT perfusion, I think I understand what you're saying. I think we've been encouraged by even the ISC presentation on option that seemed to validate our approach in the non-LVO population now even up to 24 hours. So even though we didn't know that, we were taking a pretty a collective view that CT-based perfusion analysis is fairly good at detecting mismatch. And there was another question that Sean, you shared with me prior to the presentation that I think we should have spent more time on in the guidelines. We talked about, we didn't include it because we were trying to be careful to not editorialize what happened in the trials, but actually live with what were the criteria for the trials. But the point was, when you look at the trials that were done and you look at the degree of mismatch in the trials that support thrombolysis in the extended window using perfusion-based imaging, largely CT, and especially if you look at option, which was just released in JAMA this month, the degree of mismatch in that enrolled population is quite large. So even though criteria of 1.2 ratio or 1.8 ratio are in their eligibility criteria, the actual enrolled subjects actually have a far greater ratio than that, and some are in the 5 to 10 range. And so just a fair point to call out that if you're implementing this, I think having really your team look at those trials carefully and think about how to look at that mismatch ratio when you apply it and practice it. So we've talked about it here locally that way. The guidelines try to be more fair and just say this is who they were eligible to enroll.
Excellent. Question, if you could comment on the DWI flare mismatch when it's more than 4.5 hours for IV thrombolysis.
Yeah, we largely kept the recommendation from 2019. We think the Wake Up trial largely found this to be true, and subsequent meta-analyses of smaller studies have confirmed that. We did want to say that one of the qualifiers that we learned about from the Wake Up trialists was the flare assessment was this notion of markedly abnormal, so that it had to be pretty obvious that it was on flare. So this subtle, sort of squinting your eyes and saying there might be something on flare, that wasn't what they did in Wake Up, according to the trialists who conducted it. So we did qualify that in the recommendation. Still a 2A. We think there is benefit and it's reasonable to do, but just make sure again there's a little bit of nuance to that flare assessment.
I have a quick question.
Yes.
Yeah, this is Dr. Khan from Texas. So let me give you a clinical scenario. 80 years old guy comes with a wake-up stroke. Last seen normal was 6 hours. We are in your hospital. You did CT, CTA. Your software works very good. Ischemic core is 70 cc. Your penumbra comes 2 times, and there is no LVO. Based on new guideline, we should give TNK, correct?
It's reasonable to consider. So just be careful. We're not saying should. It's reasonable. And the reasonableness allows you to think about the scenario. And the scenario in this case is somebody who's 80, has a fairly large core. You said 70. And so I'd be careful, again, just because there's uncertainty there, because the patients that were in these trials had relatively small cores. And so I'd probably have a individualized conversation that there could be benefit. There could be a higher risk of bleeding as well because of the established core.
Okay, let me have another scenario. The next day, same other patient comes with the same characteristics. 80 years old, wake up 6 hours ago, ischemic stroke 70 with penumbra 2 times, and he has large vessel occlusion of MCI, M1 trunk.
Yeah.
How should I approach?
So there, I think because of the access to EVT, which I'm assuming you're in a place where you have access to EVT, timeless for now, I think is the study that we used in the guidelines, and I think we can continue to rely on, would suggest that if you have early access to EVT, there's probably not a benefit of bridging with TNK in the 4.5 to 24-hour window. That's not true in the 0 to 4.5 hour window, but it is true in the right now in the 4.5 to 24-hour window.
Okay, let me be a devil advocate. Third option scenario. The third day, another patient comes with the 80 years old, 80 years old with same big hemiplegia, NI stroke scale 18. We do the CT, dry CT is good, no problem, no early changes, But then we were doing the CTA, all of a sudden patient got anaphylactic shock. We couldn't complete the CTA.
Yeah.
How would you approach that case?
Yeah, so you have a high suspicion of LVO, sort of the CTA couldn't be done. Now you're left with somebody who's probably has an LVO and you haven't confirmed it. There is a section a little bit on direct to angio without obtaining a CTA. And I think there's, in this case, a high likelihood of an LVO, and I think you'd probably prep them for going to the angio suite, maybe even prep them for, the anesthesia team around of compromise of the airway if anaphylaxis is the concern with more dye.
So you will not
Okay.
consider TNK in that case?
Oh, I see what you're saying. You were asking about the TNK. You don't know if there's an LVO or not, but you have a high suspicion that there is. So I'd probably say that we're in the same category where if you have access to EVT, I don't think right now we would recommend TNK.
All right. There are a couple of people with their hands up. So Benedict Tan down in South Texas in the Rio Grande Valley.
Hi, I'm Benedict. Thank you, Dr. Prabhakaran. I just have two questions. First question, has the guideline ever considered, when you talk about, disabling symptoms, does acute memory loss be considered as disabling symptom? I think this is not being well studied, and I think this should be taken into account, but because I do have patients like this, and I did a thrombectomy, and her memory immediately come back.
Yeah.
So second question.
Great question. I think the guidelines are not trying to be prescriptive around what is disabling. It gives you some examples of what is disabling and what may not be clearly disabling. But I do think I like your approach, which is to sort of think about the presenting signs and symptoms, and then think about it in the context of that individual's life, and what would it do to their quality of life and their ability to function in their occupation or in their family. And so I do think that that's what we want to encourage, more of that thoughtfulness around whether there's benefit in an individual scenario.
Thank you. The second question, I don't know if there's anyone representing the Joint Commission on DNV sitting in this lecture. Given how the guideline has changed, how is the Joint Commission on DNV going to change how we collect the metric, especially the door-to needle time thing? So
I don't know the answer to that. I think that there is going to be a performance measure writing group and a set of performance measures that are written and published based on this, hopefully within the next year. And that often helps these certifying bodies to align. And so, we'll be talking about that.
Thank you.
Great. All right. And then we have Sorlene Trevino from San Antonio.
Yes, thank you for the lecture, by the way. It was actually really great to hear the comprehensive and the updates. I was actually going to ask briefly about, and I don't expect you to be familiar, but it's more of a question. There are some states that have like emergency response networks that kind of coordinate across the state, especially regionally, to try to identify patients with systemic stroke and traumas that are flagged by EMS on the ground and then kind of get transported to the closest comprehensive center depending on their presentation. I had some time in Louisiana, and they use an emergency response network there. And I haven't really come across another state that utilizes it. I'm not familiar that Texas utilizes something like that. It would actually help with some of the updated recommendations about trying to kind of like identify these patients really early and moving them to a capable center. Because you don't need to go to a comprehensive center. And I think regionally here, they're identified by the paramedics and then they decide where to take them. And sometimes they go to a local ER before they end up getting transported, which I don't think happens often, but it would be certainly more important for the more pediatric population if it was flagged and then immediately transported to a capable center. So
Yeah.
how do we get that process started in a state that doesn't have a system like that?
That's a great question. I've done some of this work in Chicago. I'm sure many of you have engaged your local leaders and collaboratively tried to come up with approaches that work for your system. And that's what I think these guidelines begin to explore, because there are differences by region and system. And so we want those conversations to inform what's going to work best for you. And so probably the first step is finding out who your stakeholders are in your EMS system. And if there's, an opportunity to talk to them about what's possible in terms of early assessment, screening, and then activation. I think those are all the first building blocks of a policy.
Yeah, I was going to say, knowing the speaker's expertise working with emergency medicine, emergency systems is something you might want to talk to him about offline.
I'm happy to, again, share our experience. It's very much a regional one, but some of the lessons learned.
And we've got another question from Dr. Sidoroff in Oklahoma. Jenny, I think you're muted. Can't hear you.
Okay, can you hear me now? Oh, I'm unmuted.
Very soft. We can hear you talking though, but it's very soft.
I can get closer. Can you hear me?
A little better now.
Okay, so my question is about multi-phase angiogram. What's your view on the use of it in the current situation with a lot of perfusion scans available and aspect scores, and what do you think about multi-phase CTA?
Oh yeah, good question. Again, a part of the guidelines was a 2A around advanced imaging. We wanted to simplify. This was the most controversial aspect of the guidelines, and I'm sure we're going to get pilloried and about this, was, this shift from imaging selection, which of course, had become the norm since Dawn and Diffuse, towards a purely aspects-based by and large. And we left room because we recognized that even the large core trials had included things like multi-phase CT-A and collateral scoring, or perfusion imaging in their protocols or inclusion criteria. So that we felt like there was a commonality that the aspect score provides a much more broad inclusion for recommendations, but we acknowledge that, and that's why the 2A recommendation for advanced imaging was maintained, that it's reasonable to get that for your decision making and your evaluation. So I'd say if it's something that you're doing and your team is used to doing and it's not delaying care, I'd say continue doing it. If it's something you're not used to doing and your system would potentially have to delay treatment for somebody who's otherwise eligible for EVT based on aspects alone and an LVO, I'm not sure it's worth it.
Got it. Thank you.
Okay, well, we are past one. Does anybody else have a burning question for our speaker? Been great. This is why we wanted to
Awesome.
do it this way.
Yeah, I'm very encouraged by, the comments. They're very thoughtful. You guys have read the guidelines and you've thought about the trials well. Again, we're listening. We're trying to, again, think about how this is going to play out. Of course, guidelines are not, we're not dogmatic. There's lots of nuance to everything. So be mindful.
Thank you again. Really great pleasure for us. Thank you so much.
Thanks, Sean. Thanks, everybody, for attending, and the participation was great. I appreciate, again, the invitation. Take care.
Thank you.
Have a great day.
You too.
Bye.